respected chairpersons, senior anesthesiologists, and my dear friends. At the outset, I would like to thank the organizing committee, Shamshad Madam, Dr. Srijit, for this kind invitation. Patient blood management and patient safety. We have all been listening to the term blood transfusion. Now suddenly we are speaking about patient blood management. Are they different, or is it the old wine in some new bottle? There are at least 5 definitions of patient blood management, and each of these is as complex as we found the definitions to be in our community medicine days. What essentially, if you see the definition of this one given by the Society for the Advancement of Blood Management, it's a grouping of the concepts which aims to maintain the hemoglobin concentration, make sure that the patient doesn't have coagulopathy, so there is optimal hemostasis, attempts to minimize the blood loss, and with all these efforts, we try to improve the patient outcome. What's notable in this definition is nowhere they have introduced the terminology of transfusion. Not that transfusion doesn't occur in this concept, but the simple reason is they want to divert our focus, our attention, what undue importance we give to transfusion in the blood management. So it's a broader clinical approach. It still incorporates optimal transfusion strategy. Yes, transfusion has to be optimal. It still, accepts the concept of restrictive transfusion strategy. We grew up with all these terminologies, but we no longer use these terminologies for the simple reason that a change in the mindset is required, and that has to be started with the change in the terminologies itself. The shift of the focus should be from transfusion, blood components, RBC, FFP, cryoprecipitate, this, to overall, what's our aim? Improve the hemoglobin concentration, improve the coagulation status, make an effort to reduce the transfusion. So the concept of avoiding unnecessary transfusion is still there. And that's the reason why this change in the terminology also has been brought about. And when we speak of transfusion, what comes to our mind? Blood is precious, definitely. We all acknowledge that. And it's difficult to get. In fact, one of the simplest ways of getting the patient relatives cleared from the ward is start asking them to donate blood, and you will see one by one everybody clears from around the patient. And because it is precious, we now use component therapy. Every component of the whole blood is precious, so let's just give what is important. But the fashion seems to be changing every decade. One decade we tend to be more favorable towards component therapy. Next decade we think that if we are to give the all components, why give it separately? Why not give it as a fresh whole blood? So the thought process keeps changing, but the rationale behind the component therapy is let's give just what is required for the patient. Transfusion is a double-edged sword. We cannot get away with that. It will be required, but if done unjudiciously, when it is not required, that itself could be harmful. And because we have to use it judiciously, we always look forward for those numbers, for those guidelines which tell us when to give what. But remember, those are all numbers, and human beings are not machines. So that individualized approach, taking into consideration the patient features, the physiological characteristics of the patients, is also very important, and not just the numbers given in those triggers and guidelines. Very often we think that, okay, this patient has started bleeding. You never know what can happen, how much he can bleed. Let's keep things ready. Okay, ask for 4 units, ask for 2 units, this, that, keep it ready. Why take a chance? And we don't know how much time it will take for the blood to come. If there's a delay, they will ask us, why you didn't ask for it before? And sometimes when we have done that, it's there in the OT, but the bleeder is controlled. He no longer requires that, and then we are in a dilemma, whether to discard that Or as the surgeon would suggest, give it to the patient, he'll be stronger, his hemoglobin will build up. So we encounter these situations also very frequently. And I'm sure pre-operatively, the surgeons with whom we work, they see transfusion as a quick and easy way to build up the hemoglobin and solve the problem of whatever we are thinking of. So it's a balance between what anemia, what coagulopathy that we can accept versus the risks and hazards of transfusion. We acknowledge that both have problems and we have to strike the right balance. We are all familiar with the evils of transfusion. It could be acute complications, it could be delayed complications. But unfortunately, we have also found our own jugards and techniques by which we can overcome easily, so much so that transfusion has become one of the most common abused treatment modalities. Acute complications, even before you start transfusion, give an Avil, give a hydrocort, make an intern sit there, monitor, and then yes, you get through the acute complications. Not a problem at all. Non-immunologic complications, you know, all those infections that can occur, clotting abnormalities, metabolic complications. Well, we have wonderful blood banks. We have departments of transfusion medicine now. We have MD seats, post-graduation in that. And they will ensure that all this is taken care of and all these risks and hazards are mitigated. Delayed complications, they occur late. So why bother? Let's get away, tied away with the crisis, get the surgery done. This is the attitude. And that's the reason why we don't pay attention. We don't take the hazards of transfusion quite seriously. And there are some of the transfusion risks which we are not even sure about. Is the mortality because of transfusion or is it because of many other reasons which are there? Is the morbidity because of transfusion? Renal failure, did it occur because of transfusion or some other reason? So we are not certain. Cancer recurrence, does it occur because of transfusion? So when it is probably because of transfusion, we do not give importance to these at all. The real concepts of patient blood management are literally put into practice in a patient who is a Jehovah Witness. I'm sure you would have encountered Jehovah Witness. In fact, I had never done before I joined Manipal because there weren't any who came to my hospital at Delhi. But after coming to Manipal, I have had a lot of experience with Jehovah Witness. In fact, the whole concept of patient blood management began by Dr. Dental Cooley's bloodless cardiac surgeries in over 12,000 surgeries in the 1960s. And he initiated this concept of three-pillar management of patient blood component. Every blood drop in a Jehovah Witness would be important and you cannot transfuse, you're not allowed to transfuse any blood component in them. So all other principles of patient blood management other than transfusion become important in them. And the coining of this terminology, patient blood management, was first in 2005 by Professor James Bister. So the whole concept of patient blood management is based on three pillars. The first pillar aims at optimizing the red cell mass, ensure that the patient has enough hemoglobin, good hemoglobin, so that he can go through the surgery even without requirement of any transfusion. The second pillar aims at minimizing the blood loss and bleeding. So what is lost, if you can cut down on that, there wouldn't be any requirement of transfusion at all. And the third pillar says that even if the patient has lost the blood, and his coagulation is getting abnormal, still there is a physiologic reserve in this patient. Let that physiologic reserve act. Now, as long as you are not crossing that border of physiologic reserve, patient will still be fine. And you would have enough time in the post-operative period during which by natural mechanism patient will build up his own hemoglobin, will build up his own coagulation factors. So you just have to support his physiological mechanisms. That's what the third pillar aims at. So what do we do for the pillar one? We try to treat any anemia, any coagulopathy in the preoperative period itself. That's our aim. And what do we do for the pillar two? We take all measures to prevent the perioperative bleeding. And what do we do in the pillar three? We try to optimize the oxygenation, we try to optimize the hemodynamics of the patient, and we try to be as conservative as possible in our transfusion protocols. The whole thing could be made very complicated by our hospital managers. They could incorporate a lot of documentation in this, lot of processes in this, and sometimes it becomes very annoying to us. We feel, oh, we are doing this, and why do they want us to tick the box? Why do they want us to fill another form? Why do they want us to sign this, all this? But remember, when patient blood management becomes a process in the hospital, even though these look like all jargons which are diverting our focus away from the patient, it becomes acceptable by all the specialties. It becomes a process accepted, should be accepted by all the specialties. Nobody can say, no, I don't want, I will transfuse. No, there is a policy, there is a protocol. You have to fill that form, you have to do. Then it will be followed. So very simple, comprehensive anemia management, reduce the blood loss, and rational management of the chemotherapy. Is it something new which we are not doing? In fact, I feel we are the pioneers in following the patient blood management. We have been following that every day, and we try to search for every new way by which we can adopt that. Now, how do we treat anemia? Ideally, if it's an elective procedure, you need to treat anemia, give iron folic acid supplementation, build up the hemoglobin to an optimal level, and then only schedule for the surgery. And it's not for every surgery. Depending on the type of the surgery, anticipated blood loss, it would be very relevant where you expect a blood loss of more than 500 ml or more than 10% the blood volume. That's when this concept would become very important. You also try to optimize the pre-operative drug management. If the patient is on antiplatelet drugs, if the patient is on anticoagulants, you would try to withhold them at the appropriate time interval so that there is no adequate blood loss. So all in all, you're trying to optimize the patient in the preoperative period itself. And intraoperatively, what do? We are so careful right from the initial step of patient positioning. Just think of the spine surgery where we have turned him prone. We make sure we put our hand below the abdomen, make sure his abdomen is free, the airway pressures are not increased. Optimal positioning, we put the temperature probe, make sure that the patient is normothermic, because we know that hypothermia can again increase the blood loss. We give adjuvant drugs like the tranexamic acid. Yes, tranexamic acid is widely accepted. Even our surgeon friends like that so much. So it's probably used, abused also. I'm just waiting to hear that even for a cataract surgery. I think in majority of the surgeries, the surgeon makes sure that, have you given tranexamic acid? I wonder why. What's the indication? But yes, anyway, that's been incorporated. So some changes are happening. So every step, use of Surgicel. So there are nearly 100 ways. If you count every way by which you can implement the patient blood management, there are nearly 100 ways by which you can implement the components of the patient blood management. Very simple ones. Giving post-operative oxygen is also a part of patient blood management. Why? Ultimately, we are aiming at a good, adequate oxygen delivery to the tissues. So even if the hemoglobin content is a little low, you can try to balance that by giving a little more oxygen in the post-operative period. Treat the hypotension. Why? We know that cardiac output is also a factor which will determine the oxygen delivery. So we are applying all possible physiologic concepts to make sure that the oxygen delivery and utilization is appropriate. So among the three pillars, the first pillar is the weakest pillar in the implementation of the patient blood management. If I write for an elective knee replacement surgery whose hemoglobin is say 7 or 8, that you build hemoglobin, put the patient on iron folic acid supplementation. In fact, we have very good IV preparations of iron therapy also, with which you can build hemoglobin much faster, 7 days, 15 days. And I say build the hemoglobin to say 8 or 9 grams per deciliter. Schedule the surgery after 15 days. What happens? Next day, I see a hemoglobin report of 10 grams per deciliter. And what has happened? Overnight, 2 units of PRBC would have been transfused. You wanted hemoglobin to be built up. That's happened. What's your problem? But what am I aiming at? My aim is not the trigger value of hemoglobin 10 or the way by which it is done. Easily, I could have avoided the unnecessary transfusion. Similarly, if the surgeon says you are only giving a GA, so what's your problem if you are continuing with clopidogrel? I don't want to wait for 5 days. TURP, quick, 15 minutes, 20 minutes, I'll finish. But why unnecessarily subject the patient to that bleeding risk? So there are ways. So the first pillar is the weakest link, where, once again, the transformation has to happen from the surgical side. Everybody has to understand, and we have to be a little more dominating if possible in that. The second pillar, most of the things are under our control, so we do implement that quite meticulously, quite nicely. Third pillar is actually not very objective. So you say just give oxygen, improve hemodynamics, but how exactly would you do that is not very clear. The transfusion triggers are quite clear. The numbers are coming down. I'm not sure whether the numbers would still go 10, 9, 8, and now we have come down to 7 grams per deciliter for hemoglobin. Once again, beware with these numbers. It's not just the numbers, it's the clinical condition of the patient also. It's not wrong if you transfuse at 8 grams per deciliter also, if you then think that clinically the oxygenation, the hemodynamics is suffering. If there is availability of point of care viscoelastic studies, please do use them. Start using them, then it will become familiar. What's the interpretation when the reaction time is increased? What's the interpretation when the mean amplitude is decreased? What do you do when the figure looks like this? What are the components that you have to? So when you start using this, it becomes easier. Unfortunately, these equipment are kept somewhere away from the OT in some of the institutions, and it becomes really troublesome to use them. They no longer would be point of care instruments. Massive transfusion protocol is one point where, again, we are in a lot of dilemma for transfusion of the products, which product to transfuse. So have a trigger plan, make it a team approach, use tranexamic acid, use repeated evaluation of the patient, and know when to terminate the massive transfusion protocol. The patient blood management is adequately supported in the literature. Just by the implementation of the first pillar, the blood transfusion can be reduced by up to 60%. So they definitely reduce the transfusion rates. Even in orthopedic surgery, it's there. Just a word of caution, erythropoietin should not be a shortcut to build hemoglobin level in the preoperative period. Companies can promote things, so be cautious. It's only indicated in chronic renal failure patient in such situations. So hospitals could have their own algorithms, their own check barriers, where you are not even allowed to schedule a surgery when the patient is found to be anemic before 2 weeks. So only when you have such barriers in the process itself, pillar 1 could be efficiently implemented. Has it enhanced patient safety? Definitely. Transfusion rates have come down, complications have come down, incidence of acute renal failure, infection rate, thromboembolic events, mortality, they have all significantly come down. That's the reason why there is a push. I'm sure NABH would come up with its own guidelines to ensure that patient blood management is implemented across all its accredited hospitals. This large trial by the Australian group West Australian group showed that the mortality decreased by 28%, infection rate decreased by 21%, stroke rate by 31%, and the length of the hospital stay by 15%. There's a concept of 1 unit transfusion. In fact, it's quite confusing. When we were studying, they said 1 unit transfusion, if the patient requires, you shouldn't be transfusing at all. That was the concept. But now, 1 unit transfusion concept means that never ask for 2-3 units of any blood component at a time. You always start off with 1 unit of PRBC or 1 unit of the component therapy, reassess, reevaluate, and then only you ask for the next component. So your transfusion practice should change in that way. That will again reduce the transfusion rate and the complication rate. There are several stakeholders. Everybody will think they are important. So let's say everybody is important, and collectively we should ensure that patient blood management is implemented. So patient blood management definitely improves outcome. It reduces cost. It ensures that what we have, the blood products, they are optimally utilized, and patient safety is definitely improved and enhanced. Thank you very much.
Thank you, sir. Sir has rightly emphasized on the patient, how the patient blood management can improve the safety of the patient. So we should be able to practice the pillar 1, then only it will be a success on the part of anesthesiologists.
We can keep trying, yes.
Yes.
Yes, as sir rightly told, even I think sir WHO has recommended this patient blood management to be a part of the health system. So I think soonly even NABH will make it mandatory that all hospitals will have a patient blood management system in their hospitals. Again, rightly like what you told, the most difficult part will be the pillar 1, where the surgeon admits the patient the day before. If the hemoglobin is less, they just transfuse and they get the patient to the OT. So ideally, if we have to apply this patient blood management system, the patient has to be evaluated at least 2 to 3 weeks before, and the necessary corrections can be done. So rightly, like what you told, it's a multidisciplinary approach where participation has to be there from each and every person, and there will be resistance from the initial point of view itself, and which is something which might be difficult to change in the initial phase.
Other very disappointing thing is I do all the circus in the intraoperative period to preserve every drop of blood. And in postoperative ward, you see happily 2 units of transfusion being transfused, irrespective of the values.
Yeah, again, that's what, sir. You need to educate the people who take care of the patients post-operatively, and maybe you can emphasize the complications, not only the complications related to blood transfusion per se, but the chance of infection due to immunomodulations and other factors can be emphasized on the surgeons so that they might bring down the transfusion.
We will keep trying.
Any questions from the audience?
Dr. Krishna, I just want to know why you mentioned that erythropoietin should not be given. I was wondering because some of the guidelines, like cardiac surgery guidelines, actually suggest that you can give it to improve the post-operative hemoglobin level. What is the reason it's contraindicated?
The fear with the thromboembolic complications of erythropoietin and the misuse of the erythropoietin, and not really very convincing evidence that it would be a preferred agent over the very simple and cheap and much safer iron folic acid supplementation for elective procedures. That's the reason why it is not recommended to build the hemoglobin for patients whose creatinine clearance is within the normal limits for the elective surgeries. I'm not sure about the select group of cardiac surgeries. Intravenous? Yes, sir. It is there. You're talking of the intravenous therapy of iron. Yes. When we were students, intravenous iron therapy was like it's a big project. It had a lot of complications. You needed a lot of monitoring. It was painful. But the newer formulations of intravenous iron that we have, they are quite safe, and they are associated with far less complications. So there is definitely a role. It does build up the hemoglobin much faster than the oral therapy.
Thank you for the excellent presentation. Is there any evidence for perfluorocarbons, blood substitutes for perfluorocarbons in the emerging scenario?
Future, yes, but they have been telling that to be the future from quite some time. I'm not sure whether it's in clinical practice anywhere at all. So it's still at the developmental level, probably. But once that comes, and if it is free of side effects and complications, the scenario would change again, probably. Right now, no.
Sir, it was a nice presentation, very excellent. I narrate my own experience of pillar 1 treatments. My wife is a gynecologist. We have got our hospital. So we get so many anemic patients, and previously, as you said, we used to transfuse them and do the surgery. But later on, going through the literatures and that, we started giving them IV iron for 7 days, 8 days, 10 days, repeat their hemoglobin. There was a nice increase in the hemoglobin and their physiology also. So the results were very good and the outcomes also were very good. Even now also, in the evening, I do the general practice in my own hospital. So I get so many patients who has got the anemias and that, and I treat them with intravenous oil sucrose treatment, that is FAIRY, which has been available nowadays. It is very safe. I have not found any complication, any allergic reaction, any untoward reaction with that. And I use it daily. 1 or 2 patients are there with me for doing that particular part. So I will recommend that, yes, you treat the pillar first strongly and we come out of the complications which occur because of the transfusion. Thank you very much. Thank you.